ask, since I don't know this literature for FMT, but it's of interest, what kind of controls do they have for diet and other things like that that might influence the microbiome, either before or after? And when I think of transplant, the first transplants we ever dealt with were, bone marrow transplants, so there's ablative therapy before. So what about antibiotic pre-treatment? What do you think about those things, in addition to route of administration and other factors?
Yeah, so it's a good question. So usually if you're going to measure microbiome in the stool, you usually have the patient off any antibiotics for 3 months, 2 months minimum, but usually if you're going to do any trial, that's what you do. For diet, it's a really good question. I think since we don't know how diet really affects how you're going to respond to FMT, my guess is what they did is that you would so for any clinical trial, what you do is you just make sure that whatever they're on, whatever they're doing, including diet, has to be stable for 30 days so that you get a good idea of their baseline symptoms and that you don't change during the trial, because that would be bad. But that's why you always have these confounders, and that's why you have to give the strict protocol, and that's why you do it for a longer period of time. But so that's a good question. Did you ask anything else on that?
No, you got it.
Great talk, Lynn. Thank you very much. We've been doing FMT in our office for quite a while. I had a patient with IBS and then got C. diff on top of it, which became refractory. So we did FMT on him. The C. diff symptoms improved. He was left with his IBS, though. But we were using a company that allowed us to use 30 capsules all at once.
Right.
It was like $900. Insurance isn't going to pay for this. But he did improve, but the IBS was left.
Oh, okay.
Can you comment on FMT and C. diff?
Well, you probably may know the data more than I do, but it's definitely shown to be beneficial for C. diff if recurrence. Now, what I don't know is what donor they use, and if the donor for C. diff would be different than the donor stool for IBS. I'm not sure. I mean, there's also some evidence that C. diff can cause a post-infection IBS. So I don't know the data on that. But to me, what I would guess from looking at the data in IBS and the C. diff, although C. diff has been studied more, it definitely improves C. diff. I'm not sure if it really improves IBS. So that might be the reason for. And then remember think about IBS. I mean, it's a multifactorial condition. There could be other drivers than just the microbiome, right? It could be genetic predisposition. There could be other peripheral factors, and the visceral hypersensitive pain. It can be driven a lot by central processes and peripheral, so it's not as straightforward. So it's hard to take that context in one patient. I think Joel back there had a question.
Yeah, my question has to do with bloating. You alluded to the fact that it's one of those symptoms that we really do a poor job clinically addressing.
Yeah.
And what is the latest in terms of pathophysiology of bloating? Do we think it's a small bowel phenomenon or a colonic phenomenon?
Yeah, so I guess the way to think about bloating is, so you want to differentiate between bloating and visible abdominal distension. So bloating means you have the sensation of fullness or gas in your abdomen, and that's a sensation, okay? Visible abdominal distension is a sign, and that's where you actually see distension and your abdomen getting larger, where people will say, I look 6 months pregnant. That's visible abdominal distension, and they have related but different pathophysiologic mechanisms. So bloating has been shown in studies that it is linked to having rectal hypersensitivity. So like pain, it is a hypersensitivity symptom. But bloating is also associated with your diet, so what you take in, right? And that's why a low FODMAP diet helps. You're reducing the fermentable types of foods. And then gas usually means that someone is passing gas from below. So I think for bloating, what you want to think about if they're reporting bloating is you want to look at their diet and you want to try to reduce any gassy types of foods or highly fermentable foods. You also want to look as how well are they moving stool through their colon and their bowel. So you want to see in the constipated patients who typically are more bloated than diarrhea, you want to make sure their bowel movements are working, right? That they're moving at a regular frequency. So if you check the diet, so like I always say, what goes in, what goes out, and what do they feel in the middle? Okay, so if you check their diet, and then you address also, the speed by which the gas and the stool comes out, then you also have to think about the visceral hypersensitivity. because that's been also linked, just like I said, with pain. So some of these patients have visceral hypersensitivity, so you might want to try to target that with either a neuromodulation or behavioral treatment. Sometimes I think that people with more symptom-related anxiety related to their symptoms, sometimes they do well with neuromodulation or behavioral therapy. But I treat it like I do with for chronic pain if I've already addressed the diet and the stool frequency. Right. Now, visceral abdominal, I'm sorry, let me finish. Visible abdominal distension has been shown by a different mechanism. And that's been shown by ultrasound, CT, EMG by the Barcelona group. That's due to abdominal phrenic dyssynergia. And what that means is that the diaphragm is more in a contracted state, so it's pushing down into the abdominal cavity, and the abdominal wall muscles are relaxing. They think it's a neural spinal reflex that's triggered probably from having some visceral hypersensitivity. So they just published a study that they showed that the way to change this abdominal phrenic dyssynergia, it's kind of like pelvic floor dyssynergia, is that you have to do abdominal breathing. So that when you take a deep breath in, you're not contracting the diaphragm more in the abdomen. When you take a breath in, you're actually relaxing the abdominal wall, and you're not allowing the diaphragm to be in more of this contracted state. And they do it 5 minutes before a meal and 5 minutes after, and it showed to reduce visible abdominal distension.
Oh yeah, my follow-up question was, with regards to FMT as it would relate to bloating, would you expect different results if you administered FMT retrograde colonically versus antegrade via NGJ administration?
Well, I think based on that first abstract I showed you, the nasojejunal route reduced bloating.
More than...
Well, no, there's never been a head-to-head comparison. Right. So my guess, to me, just based on the data, it looks like the stool administration, whether it's upper or lower. But I think in the C. diff, they think that, I think both ways work, but I think they think that the colon may be a little more effective. Maybe that's more effective than the capsules. But my guess, from based on this data, that would help either way.
Okay. Thank you.
Does status of an appendix in or out affect durability, for example, of the stool donor status?
You mean if someone have an appendectomy, can they be a stool donor?
No.
Oh, what do you say?
The absence of an appendix prevents or inhibits durability of your donor stool. In other words, we presume that the appendix serves as a reservoir that then allows one to have a repopulation, in this case, of the donor stool. You know, in the case of the normal patient, when they have diarrhea, they repopulate their gut with their same microbiota.
Yeah, I don't know. The answer to that question is interesting. I mean, it is a reservoir. It's a small part of the whole, if you think of all of the small bowel and the colon. So my guess is it would be minimal, if anything. But unless I see scientific data with a comparison, it's hard for me to answer that question. Yes.
Two questions. I have always in the past kind of poo-pooed the probiotics thing. Now, it seems that now we are using that more and more. Now, what is the role, what are the studies showing as far as IBS and the use of probiotics? And the second part of my question is, in these studies that you were mentioning, were these people taking probiotics, or they discontinued, or, you know,
yeah. Let me just ask Kirsten, are you talking about probiotics? Okay, so Dr. Tillisch, who's the next speaker, who knows a lot more about probiotics than I do, she's going to talk about it, so maybe you can address that question. As far as these studies, they didn't say whether they were on it or not. My guess is they wouldn't be on it, but I don't know that for sure.
Thank you.
Thank you. Thank you.
Okay, as our next speaker, Kirsten Tillisch from UCLA is coming up. I just want to say thank you to the guys in the back, the cool guys, Claude, etc. Thank you for everything. Tom and the group from Pace Medical, and again, December 8th and 9th, post-AASLD. Now, Dr. Tillisch.
Thank you. I'd like to thank the organizers for inviting me back. It's always nice to be here and see lots of old friends and colleagues. So why should we know about, as gastroenterologists, know about complementary and integrative therapies? And certainly Gareth set me up with that. This is one of those questions we get asked a lot, and this is why we need to know about it. So I'm going to talk about that. I'm going to talk about mind-body therapies, which are my favorite to use, and I'm going to talk a little bit about natural products as well. So clearly the main reason for us to know about this is that our patients are interested in them. You know, certainly in Southern California, I'd say at least half of people are using some type of complementary or alternative product when we see them. When they studied this specifically, the most common indications in this paper that they described it were what they call digestive allergy, and I don't know what they mean by that, but I'm going to interpret that as people who have potentially food sensitivities, abdominal pain, and nausea and vomiting. And the most common things that people used were the herbal therapies, meditation and relaxation, and movement therapies, like yoga, tai chi, and qigong, which are much less studied, so a bit surprising that they were up there on the list above acupuncture, which I see more commonly. 80% of the people that they queried said that these were helpful to them, which I think is significant. And the other thing is that some of these therapies really have a pretty good evidence base now. They've been looked at for long enough that I think that we can make rational recommendations for our patients of some things over others, and not just let them choose based on word of mouth, internet, or the guy who works at Whole Foods in the supplements aisle. The other reason I think it's important to think about complementary and integrative therapies is this. When we see patients in the office, we're treating GI symptoms, and we're very good at that most of the time, but we don't always succeed. And often when we don't succeed, it's the rest of the iceberg, right? We ask specific questions about GI symptoms, and we often will ask about other things as well, but we're not as well trained, and it's much more difficult for us in our medical practice to deal with all the stuff that's underneath the water. Why are people potentially not compliant with their medications? People who have multiple intolerances to medications that we don't understand. People who have psychological symptoms that, regardless of whether it's a functional disorder or what we call organic disorder, can impact how well they'll respond to our treatment. What comorbid things they have, somatic symptoms. What are their coping strategies for illness that may drive their utilization of care and the number of times they come back to us with a new complaint or with the same complaint or wanting to change therapy. So those are the things that are much more difficult to deal with in practice. And it turns out that certainly in the mind-body realm, these are the things that they may help us with. So mind-body interventions for GI disorders tend to be interventions that also are useful for pain generally. So those patients who have comorbid pain disorders that may be driving utilization of care, they may be helping their migraines as well as they're helping their IBS. They may be helping their low back pain at the same time you may be helping their functional dyspepsia. And so these are interventions that help mood, help pain, and help GI disorders without us having to then put on a hat as a psychiatrist or a psychologist or put on a hat as a pain management specialist. We can still help our patients improve by sending them to these interventions. This is a recent paper in Gastro by Lori Kiefer and colleagues on this best practice advice for incorporating what they call psychogastroenterology. And it's a very nice paper, and they have these very specific recommendations of what we should all be able to do as gastroenterologists. And I think they're pretty straightforward, but one is this idea of taking a holistic, patient-centered history that includes things like these other symptoms. And so if we're asking about comorbid psychological and pain symptoms, we're asking about symptom-related anxieties, psychosocial issues that may impact their disease. We may be able to identify those people who sending them to mind-body therapies may have extra benefit. They also suggest that gastroenterologists should have patient-friendly language for discussing brain-gut pathways, for being able to describe the risk factors, psychosocial factors for GI disease, as well as how those factors may impact disease maintenance, and why gastroenterologists may refer to mental health providers if we're going to do that. And those things all kind of go together. If we help educate our patients so that they know why we're doing what we're doing, we'll be more successful in that. They also recommend that gastroenterologists should know the structure and core features of the most effective brain-gut psychotherapy. So I'm going to talk about that a little bit today. So the brain-gut connection we've extended to being really a brain-gut microbiome connection because it turns out that there probably is good crosstalk from the gut microbiota to the gut itself, to the brain. When we think about this, we know that there are some brain-related mechanisms that can drive GI symptoms, so things like anxiety, most obviously, driving symptoms. Most of us have had some experience where you feel anxious, you get butterflies in the stomach, you may have upset stomach. In our patients who have functional GI disorders, that may be more significant, so even leading to vomiting, leading to diarrhea, etc. There are also gut-related mechanisms. Like Lynn talked about with different levels of uroguanilin, there are probably dozens of different peripheral factors in our patients, certainly with functional GI disorders, that we haven't been able to identify that cause the gut to act differently and may drive symptoms. And then there are these environmental influences. So what we eat is going to affect things, whether we take antibiotics, probiotics, whether we have infections, all of these things. So it's really this crosstalk that goes back and forth with gut-related factors impacting the brain. And we've seen in large cross-sectional studies, gut factors may drive things like anxiety, depression, and then things that may start in the brain. Anxiety may drive GI symptoms. And they do this through the autonomic nervous system, through the immune system, and potentially through interactions with the microbiome. So one of the mind-body therapies that has been studied for many years is hypnotherapy. And it's one that I think is very underutilized, in part because there aren't a lot of practitioners, but also because it sounds kind of wacky and a little bit scary to patients. I think it's one that needs to be raised with patients carefully, because we all have experiences of seeing someone hypnotized, and they may have, act strangely, do something embarrassing, quack like a duck. This is not the kind of hypnosis that is done medically. And there's a large body of literature for medical hypnosis, primarily in pain. So with gut-directed hypnotherapy, people are often completely awake, even though they're relaxed, so people don't have erased memories when they go through hypnotherapy typically. I describe it as a state of focused attention that allows relaxation and internalization of positive suggestions. So what the hypnotherapist does is they have what's called an induction, so a relaxation where someone is either using counting or using visualization to calm the body down, a deep relaxation, and then a guided visualization with modulation of sensations, working on acceptance of sensations. And there's usually some sort of visualization in nature, if you have constipation, there's a stream that's flowing easily, visualization of overall health in the body, really simple kind of things. And when I first read the hypnotherapy scripts that are used, that were developed by Olafur Paulson at UNC, I was really surprised. There's very little about the gut in them at all. But when you see how patients respond to them, it's pretty amazing. And then after they're calm, you've done that, they're alerted, they wake up, and then they do this at home. So the primary part of most of these things is home practice, and they're given an audio file that they can do on a daily basis. They can be used in individual visits, they can be done in groups, they can be self-directed, or any combination. I don't usually recommend that any of my patients start with just self-directed therapy because I think it's just harder for them to get into it. But in the case where these are expensive therapies and they can't afford them, I will have them do that. These are usually 8 to 12 visits. So when you send someone to the therapist, you're not sending them to a lifetime of therapy. You're sending them to a discrete number of visits so they can really think about, okay, is this something that I'm willing to invest in? And how much of it am I willing to invest in? Does it work? Yeah, it seems to be pretty effective. There have been a number of studies. This is a graph from one of them. Most of these studies are fairly old. Compared to supportive treatment, compared to placebo pill, in different studies. Hypnosis shows greater improvement in a number of GI symptoms. And what they've done in the UK, where this is a standard of care in many practices to use hypnosis, is follow-up studies 5 years later show persistent benefits, something that we don't often see with medications that we stop. So initial intensive treatment for prolonged benefit is really what we're looking at. And they show decreased utilization of medications, utilization of healthcare. We also have seen this in functional dyspepsia, so hypnosis has been used the same way in functional dyspepsia, also in children who have IBS and dyspepsia as well. So how might this work in IBS or in other disorders? What we did with a group in Sweden that uses hypnosis as part of their standard practice is we looked at the brain in experimental trials, and we gave them a visceral pain. So they had a rectal balloon distension that was painful. And a healthy control looks like this in the brain when you say, we're going to blow up this balloon in just a second. So they deactivate part of their prefrontal cortex, and they activate part of their anterior insula. And that's a normal response. And their brain actually looks quite similar when you actually blow up the balloon. So the brain prepares. In IBS, it looks like this. So you see a lot more going on. This is the thalamus, our primary relay station of sensory sensations from the rest of the body, and the insula bilaterally. So the brain really prepares differently in IBS. And we think this is one of the mechanisms, this anticipatory anxiety. And then after hypnotherapy, we looked at them. So they did the standard hypnotherapy that Olafur Paulsson uses as well in the other studies that we showed. And they look like controls now. So it turns out that the brain does change when you do these interventions, and it probably changes particularly in those parts of the brain that induce anticipatory anxiety for symptoms. So that I'm afraid to eat because I'm afraid that I'm going to have pain. Or I'm afraid to leave the house because I'm afraid I'll have diarrhea again. Lori Kiefer and colleagues did a study just recently looking at hypnosis for inflammatory bowel diseases as well, and this is an area that's becoming more popular, looking at can we do things to improve quality of life and improve the duration of remission in patients who have IBD. So these were quiescent ulcerative colitis patients compared to an attention control. And with 7 sessions at a 1-year follow-up, they showed that those patients who had hypnotherapy had a prolonged remission compared to those who had the control therapy at a year. So 78 days longer on average, longer remission in the hypnotherapy group. And previous studies have also shown some changes in rectal cytokines, inflammatory parameters in IBD patients who had hypnotherapy. So there may be some ways that hypnosis may change inflammatory processes. So how do people find a hypnotherapist? These are usually psychologists. They may be other licensed therapists. And what I usually ask people to look for is someone who has another clinical practice, who has familiarity with GI protocols or is interested in familiarity with GI protocols, and have specific training in hypnotherapy. This website, ibshypnosis.com, is run out of University of North Carolina. They have a lot of education for your patients, and they also have lists of people by state and region who are trained in these protocols. The other similar treatment that I recommend is gut-directed cognitive behavioral therapy. And it's also a time-limited intervention. It's a skills-based behavior modification protocol, and it identifies and adjusts dysfunctional thought patterns related to gut symptoms, pain, and distress. So it uses education, it uses relaxation, it uses breathing techniques, cognitive restructuring, and exposure intervention. So sending people to a stressful place and having them practice relaxing and tolerating these events. And what you can see here is that people in what's called minimal contact CBT, so they meet with a therapist and then they do the rest of it online, so it's much easier. or standard CBT, where they meet with a therapist each time, which also works, but actually the minimal contact works better, or an education intervention, people do better when they get CBT. So it's equally effective. In an abstracted DDW this year, we showed something we thought was interesting, a connection with the microbiome such that people who responded to CBT had a lower Bacteroides and higher Clostridiales at baseline, so a different microbiota profile at baseline. And these responders also had higher fecal serotonin. So it may represent some substrate of people who may do better with CBT. One of the things we're always looking for is, who do I send to CBT versus hypnosis versus give them standard prescription therapy? And so there may be something in these people who are responders that's different on a biological level. Again, it's hard to find somebody who's a qualified CBT therapist. On a practical level, just sending someone to a therapist is not always the best idea. I know that in my practice early on, when I tried to do this, I'd send people to a therapist that people had recommended, this is a good therapist, but I didn't necessarily ask if they were familiar with treating medical symptoms or gastrointestinal symptoms. They go, and then the patient comes back and they said I'm fine, that I should just see you for my bowel problems. And that's disrupted the relationship with the patient, because they think, why'd you send me to the therapist? I just paid for this. And you didn't get any benefit. So it's really finding a therapist that understands why you're sending the patient. And so having a relationship with a therapist that you can call them up and say, okay, I'm sending this person for regurgitation. I'm sending this person for abdominal pain, etc. So that they know why you're sending them. You're not sending them there because they have anxiety necessarily. You're not sending them because they have history of poor relationships in their families. Whereas a family therapist often will go to the things that they know. They won't go to the GI symptoms. A good CBT therapist for GI symptoms will have some additional interest and or training in this area. And there are not a lot of them, but you can find them in some of these places. I also put up a plug for, it's not really a plug, but Jeff Lackner's book, I don't know, maybe 5 years ago, he put out that, or longer, this 10-step plan for symptom relief. He goes through cognitive behavioral therapy very, very intensively for a patient with IBS. And there are some patients who do really well with this kind of self-teaching intervention. But even if you don't have a therapist that is familiar with this kind of work, giving them this book can help them in treating the patients. Mindfulness-based stress reduction is the third mind-body intervention that I think can be really helpful, and there's been increasing data on. Mindfulness-based stress reduction is, again, a structured implementation. It was developed many years ago to be used in a medical setting specifically. So this is not saying you're going to become a long-term meditator and this is a huge life change. This is a practical class where you learn techniques to change your symptoms and mood. And they incorporate education, a little bit of yoga, not much, and some meditation in a 9-session course, 2 hours each. The aim is to enhance present moment awareness, reduce judgment, promote well-being. And the way that this relates to gastrointestinal symptoms is really that anticipatory anxiety. What are people worried about? What might happen? What happened last time I had symptoms? And what might happen if I have the symptoms again? Are these symptoms going to make me lose my job? Am I going to not be able to go to the movies? Am I going to have an accident in the grocery store? All of these things that are going on conscious and subconscious levels with our patients all the time. And this kind of hypervigilance to symptoms that actually make symptoms more unpleasant and sometimes even make symptoms more likely to occur are dealt with this type of intervention. When it's been studied in meta-analyses, it has been shown that mindfulness-based stress reduction helps pain, anxiety, depression, some small studies showing benefit for post-traumatic stress disorder, and helps IBS. So in this study from 2011, Gaylord and all showed that MBSR reduced overall symptoms. So using the IBSSS, which Lynn talked about, with a fairly robust, greater than 50-point drop in symptoms that persisted into a 3-month follow-up. So again, think about what drug you have that you can stop the person, check them 3 months later, and they still had benefit. Plus, they also probably had benefit in their mood. At DDW, we had an abstract looking at brain mechanisms, again, in this disorder, in 63 women who had IBS, men and women who went through MBSR training. They had an IBS symptom severity decrease of about 75 points on average. And that improvement that they had correlated with changes in parts of the brain that are related to emotion regulation and sensation. So those very areas of the brain that we think are acting abnormally in patients who have functional GI disorders. Where can patients learn about mindfulness? Because again, this is not something that you're going to be doing in your office. UMass Medical School is where a lot of the training is done. That's where John Kabat-Zinn developed this intervention. And they have a website where you can find people who are trained all over the country. Mark, the Mindful Awareness Research Center at UCLA, does a lot of training of people in Southern California. They have a website, again, that can be helpful. And then the Mindfulness Coach is one of the phone apps that was developed by the VA for patients with PTSD. But I tend to recommend it for patients with other disorders as well. It's a very simple, easy-to-use mindfulness app. But again, there are dozens of these out on the market that people can access. So I put this in here, one as a way for me to tell where I was in my talk, but also just so you can read some of the things that people say. So people write me these letters. I don't think I've ever had a patient that I treated with linaclotide that wrote me a letter that told me how I changed their life. It's very rewarding when you can give a person a referral, and a referral that you've given with enough education and enthusiasm so that they actually follow up with it. And then they come back and they say, wow, you changed my symptoms profoundly. And not only did you change my symptoms, but you also changed other aspects of my life, like my anxiety and how I deal with other things. So hopefully you had a chance to read that. Really can make profound changes for people. Just to comment though, these changes, when we look at them over 6 months, a year, they tend to be fairly robust. There's not a lot of longer trials, but those longer trials that have been done in mindfulness and in CBT show a really steep sort of decline once you get past a year. We probably need to make sure that we're doing some continued intervention at a lower level to maintain these benefits so that patients don't lose them over time. So the movement therapies are another mind-body intervention. There's a lot less research on these, but there was a systemic review of yoga for IBS that indicated that they thought that there were benefits. These are low-quality studies. They're all small. They're not well described. We need a lot more study to know. There's so many different styles of yoga. There's so many different intensities of yoga. It doesn't tend to be one of the things that I just give people a prescription to try, though I think that there probably will be some benefit, particularly for restorative type yoga that's using these same relaxation mechanisms, breathing mechanisms that seem to help in the other mind-body interventions. It's not really clear at this point if there's anything specific to yoga that makes it better than other exercise. Some studies show that it doesn't seem to be any better. Studies in pain, particularly chronic back pain, and studies in depression have shown that yoga is beneficial. So there might be something to keep an eye on. And also just if you have a patient who this is something that they gravitate towards, I'm always positive on how it may help them in ways other than exercise. In acupuncture, I do acupuncture at the VA for pain. I see a lot of great benefits. The data in GI isn't nearly as good as the data in just chronic musculoskeletal pain. There is some data that suggests, particularly in nausea, vomiting, acupuncture is helpful. There's some studies that show that it's helpful for constipation, a pretty intensive electroacupuncture therapy for constipation, and dyspepsia. There have been mixed studies in IBS. Probably better than a wait list, but not better than sham. Probiotics, so as the person asking the question earlier, and I like poo-pooing them in the context of FMTs, should we poo-poo the probiotics? I've never been a hugely impressed by the effects of probiotics. I think we have a lot of difficulties, but there is increasing data that suggests that they're helpful. The difficulty we have is most of the probiotics have never really been shown to be effective, most of the ones that are on the market. Most commonly, people will use lactobacilli and bifidobacteria, and those are the ones that we have the most data on. But probiotics can be found in many different ways. So there are the pills, and those are the ones that tend to have some clinical trials behind them. But there's also probiotics in yogurt, and increasingly there are a few trials that show that yogurt does help digestive health. And then there's just fermented foods, what people eat in their diet that may be fermented and they get some benefit from. How might probiotics work? Well, certainly the three main ways that we think they might work are in regulation of the immune system, in altering metabolic activity, and that's where they may be helpful in looking at things like weight management, and improved mucosal barrier function, and this is where they are thought they might be helpful in IBS and in IBD. The way that probiotics work, as shown in this figure, is really quite complex and depend on many, many factors. So they're going to depend on host factors like what other bacteria are within the gut. Each of us have a microbiota profile that is unique and identifiable. And so it's really hard for me to see how giving us all the same probiotic will affect us all the same way. We're not yet at the point where we're able to say, okay, your profile, and I'm sure you guys get people coming into you with their gut microbiota profile, as I do. This is what mine looks like. What should I take? We're not at the level of doing that, and so when I have patients coming to me and emailing me, should I get this? Should I get this from this company or this company or this company and get my profile? I always say, if you're interested, you could do it, but we are not. This is not actionable evidence at this point. We know how important the gut microbiota is, but we don't yet know how to modulate it. So as important as it is, and how we do have a good understanding of how the bacteria within the gut act within our immune system and act for mucosal barrier, we're not sure how to implement this practically. So do probiotics help IBS? The biggest, and I think a very good meta-analysis is really an old one that looked at 18 studies with 1,600 subjects and looked at probiotic versus placebo on global symptoms or pain. Overall, they felt the study quality was good, and they showed that the relative risk of symptoms persisting was 0.71, so a benefit of probiotics with a number needed to treat of 4. So small benefits, no differences were seen in this study, in this meta-analysis, between the type of probiotic used. But I think most of us see in our clinical practice, it's a rare thing when we have someone who really has a robust response. It does happen, but most people have small or no response. I thought this was an interesting study that came out last year looking at probiotics in mood and IBS. So Bifidobacterium longum was developed as a treatment for IBS. They found that it didn't help IBS symptoms, but they used it specifically to look at depression and anxiety symptoms in IBS because comorbid mood disorders are so common. And in this study, they found that this probiotic decreased depression scores specifically. And they did that in conjunction with decreasing activation of the amygdala, which is an area that's activated in fear and anticipation. So there may be some ways in which probiotics may help some of the comorbid symptoms of IBS, as well as specific symptoms, though in the case of this one, they may need a combination of probiotics to help mood along with GI symptoms. What about functional dyspepsia? In this study, some of the outcomes showed significant improvements in functional dyspepsia. In the global improvement shown here, there was just a trend towards a benefit, but it does appear that there may be some benefits in functional dyspepsia as well. What about IBD? In this recent meta-analysis, it looked like probiotics may help prevent relapse and quiescence, you see, so barely significant favoring probiotics here. In another part of this meta-analysis, they showed that VSL number 3 specifically may help induce remission. At DDW, there was an abstract looking at probiotics and weight. So looking at lactobacillus probiotic to reduce body mass index, body weight, and fat mass in overweight and obese subjects. And this was a systemic review and meta-analysis that they performed. And they wanted to look at the probiotic dose, the duration of use, and diversity of the probiotic on these weight-related parameters. They had 15 studies in the meta-analysis, so there have been a number of them now. And what they showed is that indeed in their analysis, probiotics led to significant decreases in BMI, body weight, and fat mass. And that reduction was most significant in people who were using lactobacillus versus combination probiotics and using particularly high doses. Small changes, but interesting. Current limitations, I've already sort of touched on. So right now, we just don't have enough research to say what dose, what duration, what mode of administration, and what individualized formula we should be using. If we're going to use them, Lactobacillus bifidobacterium are what we're going to use. In terms of the way that I usually prescribe them, I start with the ones that have a little bit of clinical trial data. So Bifidobacterium infantis, Lactobacillus GG, there are a few. And then I go from there. If patients have a probiotic that they're taking that they think is helpful, I'm fine with that. If they try one and then want to try another one that somebody really liked, fine. The risk is really low. The only thing I think is really important is to identify whether the probiotic is helping or not. Because often people will come and they'll say, well, I've been on this probiotic for years. And I say, is it helping? And they're like, I don't know. Like, well, why are you taking it for years? They just think it's helpful that they should for their health. It's kind of like people just taking PPIs forever. It's just not necessary, and they really should just stop them because they're just wasting their money. If they are helpful, great. Go ahead and take them. We know that probiotic, as soon as you stop taking it, within a week or two, it's gone. It doesn't populate and become part of your microbiome, unfortunately. It doesn't stay with you. So I usually just have them try it for a month. If they can say they definitively notice, they feel better, great, continue it. If they cannot, maybe it helps a little. It doesn't help. I usually recommend they stop it because of the cost. There are some natural products. Most of you are probably familiar with the peppermint oil, so enteric-covered peppermint capsules, been around for a long time. IB Guard and FD Guard coming online a few years back, used for dyspepsia and for IBS and can be really helpful. Peppermint acts as an antispasmodic on the smooth muscle of the bowel. And people mostly tolerate them well. Occasionally you'll have patients who have an increase in GERD, and I always give them that warning. And less often you see nausea or perianal burning. Ginger root has increased evidence recently as a treatment for nausea vomiting in adults and in children, and it can be used in capsule form. Some people just use it as a dietary. The risk of that is some formulations of ginger can increase the risk of bleeding. So people on Chinese ginger in particular, you want to make sure they stop it several weeks before they have any procedure. I certainly had a bad experience with that with one of my patients who forgot to tell me that she was taking a lot of Chinese ginger. It's just this little biopsies in the stomach, just bled like crazy. Traditional Chinese herbs have not been studied for a long time, but the older studies in IBS did show some benefits. This is something that I'm cautious with because we don't it's a whole nother line of medicine. If I have a patient who's working with a traditional Chinese medicine provider who is reputable and I'm comfortable with, and I have a few that I do work with closely, I'm fine with it. But I don't have people do any off-the-shelf traditional Chinese herbal medicine due to risks. And then SDW5, which is brand named Iberogast, can be helpful for IBS and FD. And what about cannabis? So we've heard a lot about it already this weekend. 22 million users in the US, so we have less than 2 million patients with IBD. We've got maybe around 22 million folks with IBS in the US. For perspective, this is a lot of folks. And we kind of have to learn a little bit about it now because particularly in California, many of our patients are on it. Two main active ingredients, though there are hundreds of active ingredients in cannabis, are THC, which is the main psychotropic component. So that's the component that gets people high. It's also the component that's been associated with psychotic episodes, that's associated with the kind of paranoia and anxiety that some people get with marijuana. And CBD, which is its balancing component, which is thought to be potentially anti-anxiety, antipsychotic, and anti-inflammatory. So has some potential benefits that may be helpful in our patients. They both work on these two receptors that I think it was Dr. Salk who was talking about them yesterday, CB1, CB2. THC predominantly interacts with CB1, which is all over the gut and the epithelium and also in the enteric nerves. CB2 is preferentially bound by CBD, and it's more associated with immune function. And so as people are changing, especially as we're shifting towards recreational versus medical marijuana, the level of THC in marijuana has increased substantially over the last 20 years. So we're shooting towards in that direction. Increasingly, people are starting to realize, well, what about the CBD products? Those may have some of the benefits. So looking at the ratios between the two is probably important when we start to think about medical symptoms. This figure is adapted from a recent article. It turns out there are some studies that have looked at the effects of a cannabis on the liver, effects on fibrosis, and they've gone in both directions. I'll show you a recent abstract in a minute. It appears that cannabis decreases gastric motility as it does, at the same time it's increasing appetite. It decreases motility and secretion in the rest of the gut and may have some effects on immune function. But it also may induce pancreatitis, and that's less well described. This is the abstract that Dr. Salk talked about, so I'll just mention, since you probably already heard about it, this improvement in ulcerative colitis with cannabis. So in Israel, in their medical cannabis program, most of it is smoked cannabis, and they have THC-enriched cannabis. So basically their medical market comes from regulated farms that produce the cannabis at specific levels. When you think about, and you've talked to your patients, ours are getting it in all different forms, in oils, in smoking it, etc., in edibles. So this suggests that there's a benefit. The benefit may be even better if the ratios of THC and CBD could be shifted. This is another abstract that was at DDW on cannabis, and that's this one on hepatic fibrosis. And what they looked at was different etiologies of liver disease. And so you can see in HCV favoring non-cannabis users, though not significantly. When you look at HCV plus HIV, it looks like it may favor marijuana users. And here in NAFLD, potentially favoring marijuana users. So again, depending on what the actual product they used to do these studies was, there may be different benefits. And so as we start to look at these studies, we really have to look at what types of cannabis products they're using, and could we potentially get some increased benefit for our patients if they're modulating them carefully. And then finally, is it all just placebo? I love the placebo effect. It's not a dirty word for me. This study, I always like to throw in an older study from Tony Lembo and Ted Kapchuk looking at Open label placebo. Patients who have IBS who are given a pill, and this is a placebo, which is a sugar pill that doesn't have any active effect, and this has been shown in the past to benefit symptoms in all kinds of different disorders, and giving that compared to no treatment in a very short study actually does improve symptoms in IBS significantly, and does because it is given in a supportive patient-practitioner relationship. Which is hopefully what we all have with our patients. So we can improve symptoms, adequate relief, and quality of life by our patient interaction and potentially the placebo that we give the patients, at least in short term and at least in people who are genetically predisposed to be high placebo responders. Really, the best placebo of all is you and how you're going to interact with your patients. And I do think that understanding some complementary and integrative approaches to treating different disorders is part of that. Respecting the patients, their wishes, and what they're interested in. Not necessarily becoming experts in any of them, but at least knowing which ones may have some good data to support their use in your patients. So which to choose, it's really hard to know. We are still gathering evidence on all of these, but I think that hypnotherapy, cognitive behavioral therapy, and mindfulness are good ones to go with. But really, it's going to be what your patient's interested in and what you have access to. And I'm happy to answer any questions you have.